we had to sort of draw a line. Needless to say, questions are always welcome. You can send it to us directly, or we'll figure a way out to get them fielded. So we've been through a journey, right, since morning, as I said. Started with challenges, looked at some potential ideas, got some different perspectives, started talking about technology that can, facilitate some of those solutions, and also tried to see if, those solutions can actually be relevant to the emerging markets. But then, at the end of the day, what's important is outcomes. Are all these solutions actually resulting in outcomes that will make a difference? So the next panel discussion is exactly on that. The topic is achieving better healthcare outcomes, value-based models needed in the emerging markets. Again, focused on the emerging markets. And to moderate that discussion, we have our very own Shivakumar, KR. Shiva, if I can request you to take the stage. A very quick introduction. Shivakumar is a fellow architect in the Chief Architect's Office at Philips, located at the Philips Innovation Campus in Bangalore. He's been with Philips for about 21 of his 28-year career, and he's part of his role makes him work on healthcare solutions, which is going to be eminently relevant for the discussion that's going to happen in the next 1 hour. With that, I'll leave the stage for Shiva and his panel.
Thank you, Sriram. And if I could now please welcome the panelists to join me on the stage. Look at all the sessions that have happened and the perspective that we got from Kalavati and then from Yeruntas gave us a view on how a technology company that is trying to pursue healthcare and value-based care looks at it. And then we had a rather grounding session from Dr. Shetty, who gave us expectations that a practitioner like him has. Then we got the perspective from Hiro-san on something like Japan, and a very interesting conversation that just concluded now. So now, in continuation of the spirit that's already been said, we'll be looking at how we are going to achieve better health outcomes using value-based models with a focus on emerging markets. But before I continue, I'd like to quickly introduce the panelists that I have today. Sitting to my right is Rohit Sathe. Rohit Sathe is the president of Philips Healthcare India subcontinent. He has over 2 decades of rich experience in various industries in healthcare, construction and e-learning, and in India and the United Kingdom. As part of the India leadership team, Rohit oversees key initiatives to improve access to care in the area of prevention, diagnostics, and treatment. Welcome, Rohit. Thank you. To my left is Dr. Nakagawa. Dr. Nakagawa is an MD, PhD, specializing in neurology and neurosurgery. Currently, he is the co-director of the Japan Biodesign that hosts more than 50 companies and 1,300 researchers whose focus is on clinical innovation in addressing unmet needs in healthcare. He's based out of Tohoku, and Tohoku is one of those locations in Japan which has the highest aging district, as it's called. Close to 45% in certain portions of Tohoku are elderly people, and the situation there has worsened since the tsunami of 2011. And he's a very accomplished individual, and he's a special appointment of professor and director of the Bedside Solution program in Tohoku University Hospital. In addition, he is a special assistant to the director of Tohoku University, focused on industry alliances and technology. According to Dr. Nakagawa, he's more in between somebody who's looking at design and value and an actual clinical professional. So I'm sure he'll bring a very interesting perspective. To the left of Dr. Nakagawa, we have Sean Carney. Sean, of course, a lot of you already know, is the head of design in Philips, and he's also the general manager of healthcare transformation services. He and his team are instrumental in creating many of award-winning designs that we deal with in our day-to-day. And most recently, we've received the Red Dot Design Award for the best of best in brand. Welcome, Sean. And last but not the least, we have Dr. Tony Raj from St. John's Research Institute. Dr. Tony Raj is the Dean of St. John's Institute, Professor of Physiology, and currently he has more than 18 years of experience in medical informatics, and he has a focus on many things, and amongst them is artificial intelligence. He is the Chief of Information Technology at St. John's for 5 years and is responsible for many of the digital transformational initiatives like introducing a RISPAC system. So that's the panelists for the day. So let me get started by actually trying to give in brief what we've discussed during the day. We saw the fact that there is a need for us to move from volume to value. It was quite obvious when you saw what was said in the morning. Today we have a situation where the demographics are changing. We do not have enough professionals there, and there's a lot of cost pressure on the system. You have countries like the United States that are spending close to 20% of their GDP on healthcare. And if you look at that spend, compare it to the kind of outcomes you have, it's completely unaffordable. And you start finding the fact that the same trend is there across the world. So the ability for us to strike the balance between outcomes and cost is really a bit of a conundrum. And this is what we are looking to solve. And today we are going to quickly touch upon trying to see what is it that we can do to address this conundrum, if I call it that. Today there's a lot of waste in healthcare. We find if you take a procedure that is done in one hospital and go to another hospital, they're probably going to ask you to take the test once again, amongst other things. So what is value-based care in that sense? So value-based care in that sense is really, it's an economic and organizational framework that one relies on in striking the balance between outcomes and costs. And it's really a question of looking at, if you've done the right thing versus making sure it's the right thing to do, It could be a case where you do an imaging procedure and you follow the procedure and the steps perfectly. But did somebody ask the question of whether the procedure was needed in the first place or not? That's the consideration that should apply. In that context, if you look at what Yeruntas said in the morning, the question of quadruple aim, I think that is central to the way we as Philips look at value-based care in terms of looking at outcomes, looking at cost, and looking at the experience that's there both for the patients and for the physician and technicians who are actually working in the system. Now, having set this context, let me start by asking each of the panelists what their perspective or what their view is on value-based care. And I'd like to start with you, Rohit, if you could just give us your perspective as to what you see value-based care as and how do you look at it in the Indian context.
So, India, they say, is not one country. India has many Indias in it. The way we at Philips look at value-based healthcare depends on which segment you're looking at. The private segment has a different connotation to what value-based healthcare is. The government segment has yet another. We've all heard about Ayushman Bharat, which is the universal health scheme that our Prime Minister announced with a cover of about 5 lakh rupees. That incidentally is the same cover that most people in multinational companies, even like Philips, get as well. So clearly very, very comparable. However, the government, when they decide on Ayushman Bharat, they have spoken about a procedure cap. So it becomes imperative for all healthcare delivery institutions to deliver quality healthcare with that cap that they've set out for every procedure. Now, how we look at it from a Philips perspective is to look at that total cost of ownership, which enables our customers, which is the healthcare delivery outfits like hospitals and diagnostic centers, to deliver quality care, to enable them that quality care within the price cap that has been set by the Government of India. On the private side, it is also to look at how growth is happening, not just in the metros, but more growth is happening in tier 2 and tier 3 cities. Given the kind of demand that is there for these procedures, how do we ensure that an asset that we provide to them in the form of an MRI or a cath lab or what have you is something that they can pay for? Okay, so there comes in financial models of risk taking, maybe EMI-based payments and all those types of things. So our role as the industry over here is essentially how do we enable quality delivery of healthcare, whether it's the private segment or the government segment.
Thank you, Rohit. That's an interesting perspective. Now I'll kind of turn to you, Dr. Nakagawa. You've been part of the Japanese healthcare system. So how do you perceive value-based care from your context?
Thank you, Shiva. So like Shiva introduced me, I'm a physician and also work with a business like Hiro-san. And I also work in the government and participate in designing the future of the Japanese healthcare systems recently. So as you might know, Japanese current universal healthcare system has been developed and designed in 1961. And at that time, I think the healthcare budget was 4.1% of the GDP. Mm-hmm. But surprisingly, recently, the percentage raised around 11%. That's because super high aging societies, so almost 30% in whole Japan, over 65, and also decreasing population of the birth rate is tremendously decreasing. So in 1961, about 9 productive age people supported one elderly population, but now 2 people support one elderly population. So as a nation perspective, we need to change definitely from volume, based on way of thinking to value-based way of thinking. So it's mandatory right now. But as physicians and also kind of a liaison between the medical and industries, I think living in those elderly populations, I think it is very, very, when we design the systems, we need to define whose problem we are going to solve, what kind of problem, and what's the desirable outcome. And living in Japan, so many elderly people, and which is bringing the complexity of the programs, mm-hmm. and diversity of the kind of measuring the outcome. So I think we are also as a physicians and also business liaison, we are facing every day value-based medicine. Everyone agree with that, but how do we appreciate and evaluate and benchmark the outcome or value? And how we design, it's more complex and complex. So I think everyone agree with the shifting toward the value-based care in Japan, but we are also at a loss how to design, how to define, how to evaluate, how to benchmark those programs. Thank you.
Yeah, thank you, Dr. Nakagawa. That was very interesting in terms of the fact that there's acknowledgement for the need, but it's not very clear how to go about it. So if I shift to you, Dr. Raj, now, in terms of looking at your perspective, coming from St. John's, and also letting us know how you view value-based care, and give us your view on it, please.
Sure. Thank you, Shiva. To me, value-based care is moving from a fee-for-service kind of model to keeping the patient at the center of the care, delivery process. Coming from St. John's, as you said, St. John's has in its mission statement to kind of keep the patient at its core. This is a difficult model because as we've seen medicine evolve, we've seen medicine move from the family doctor kind of practice we had several decades ago to now specialists and super specialists. Even in hospitals, tertiary care hospitals or any hospital, one specialist, you see one specialist and you go for another condition to another specialist, it's very siloed. And sometimes, and this is what we see as well, patients go shopping across hospitals and finally come back to a tertiary care center in a delayed state, and sometimes it's detrimental, it's fatal. It costs money as well. So trying to shift the focus from a fee for service to measuring outcomes, but moving it to a care team. There are models in cancer care, for example, where some of the hospitals have a care team, and even in Bangalore. There's a radiation oncologist, a surgical oncologist, the medical oncologist, the psycho-oncologist as part of the care team with the patient and the relatives. Now that's a fantastic model. But can we do this for all conditions? Mm-hmm. Can we expand that? I mean, can we move back to measuring outcomes and what works, what doesn't work, and then definitely move on to seeing how technology can help in that.
Yeah, thank you. Interesting. Sean, coming to you, and from your background as a designer and also looking at it from a corporate perspective, what is your view on value-based care?
Yeah, we've heard from a number of the panelists already that there's a number of challenges, but there's also some answers already starting to surface here as well. So I think when you look at value-based care, it's really about looking at an end-to-end efficiency across the care pathway, the care continuum. And at the moment, that care continuum tends to be very focused around medical care. And we've got to change the discussion to be more about health care, which means we go outside of the hospital system and start to look at patients before they enter the hospital system and after they're discharged from the system as well. And by looking end-to-end in the way that we talked about earlier in the care continuum, we can really start to drive efficiencies and outcomes. Now, the challenge that we've got today, as I see it, is that, to the point that you just made there, we have a lot of specialists, we have a lot of different clinicians, a lot of different people interacting with the patient. And I think, as Jeroen mentioned this morning, at the moment, the onus is on the patient to be the care coordinator. And that cannot be, because they will never drive those efficiencies on behalf of the healthcare providers. So the digitization of healthcare offers the opportunity, I think, to connect those points of interaction across the care continuum and help us identify where we can find efficiencies and drive better outcomes for patients. So I think there's a lot of opportunities here, but we've got to now work together with healthcare providers, technology companies, device companies, and patient advocate groups to really drive this efficiency.
All right, thank you for that. I'd like to just shift the question and maybe ask the clinicians in the panel. Dr. Nakagawa, if you start looking at your experience with value-based healthcare, how do you see it in day-to-day practice? Do you think that the current way it's being done, there is even this notion of value-based care in the current day-to-day practice?
Yeah, thank you. So I partially worked in San Francisco and Stanford University. So recently, I think most understandable, value is like, kind of shortening of the hospital stays, or kind of reducing the number of the, readmission or something like that. It's understandable to the every physicians, and I think it's more each physician can know more concrete way to achieve that, but there are a lot of values other than that. It's not so simple, and it's more variety. So, and I'm almost 23 years has experience of us as a physicians, and facing with a lot of patients and medical professionals, there is a lot of values that we have to appreciate. So, which is more important and which is not, we cannot decide that. And so the point is, I think we agree to the notion that value-based care is very important, but how to achieve that? How outcomes or values, and how can we achieve that? So I think I would like to stress about the importance of the liaison people or designer people who work with the medical professionals and hospitals.
Okay. That's rather interesting in terms of the fact that it's this aspect of co-creation that you're stressing on, and I think that's quite wonderful. It's also the uncertainty in trying to pin down where the value is, that also brings the opportunity at this juncture. So if I now turn around and look at you, Dr. Raj, and say, if you look at your day-to-day practice and you try to associate it with value-based care as you see it, what's your view? How well is it thought of or understood?
Sure. I can share an example from our hospital. Several years ago, maybe at least a decade ago, St. John's, as I mentioned earlier, caters to low and middle income families and populations who otherwise have very little money and they're paying out of their own pockets, no insurance cover. Now, there were kids who were coming with deformities in their limbs, clubfoot, for example. And one of our orthopedicians decided that we'll start working with these patients and offering free surgery. But this has now evolved into a value-based care system where it's not just the orthopedic surgeons. There are kids, many a time, besides having physical disabilities, also have mental and other disabilities. So we've created a unit of hope, which we call it in St. John's, which have multiple care teams. So a kid who has disabilities, mental disabilities, physical disabilities, is treated by an entire care team, including a child psychologist, the orthopedic surgeon, and people trained to deal with children with special needs. And it's a comprehensive care that we deliver, but they don't really pay out of their pocket. We've figured out a way in which to generate money from charities, and we've created infrastructure. So there was a certain innovation in process, and there was an innovation in trying to get this team together, and it's been running, I would say, for a decade now.
Okay.
In the oncology model, again, we have patients who don't have money, but cancer care is expensive. So there's a similar model where we look at what works. We look at protocols that should be, what's the ideal protocol for treatment, but what's the best that would work for what this patient can afford. Again, that's the model that we're exploring, but it's not easy. We cannot expand this to every other specialty because the volumes are our challenge. We get 3 to 4 minutes per patient. So again, that's a challenge that physicians have to deal with.
All right, thank you about that. So Rohit, turning to you and kind of changing the nature of the question. In your experience and your view, when it comes to value-based care, what do you think ought to be, say, an organizational strategy or even the strategy for a nation? How should they be thinking of addressing this more from a strategic perspective?
So I'll tell you how we think about it, or what our strategy or my strategy is for Philips Healthcare. Philips is trying to move worldwide. We're trying to move from products to solutions. Okay. Now, what does that exactly mean in the context of value-based healthcare, and specifically in India? So we're not going to be selling products just on the strength of what technical aspects that particular product has, or how brilliant the electronics is, or how sharp the display is, those types of things. I think we have to look at it in the context of all the pain that we are talking about over here, that our customers face, and in different segments, okay? So let me give you an example of 2 things. The strategy involves, the kind of products that we sell out there, and also the business models or the go-to-market models that we have for delivering these to our customers. So from a product perspective, let me give you 2 examples of, or maybe one example of where this really helps us. If you look at the price of an MRI, okay, it's the same whether it sells in India or it sells, in Japan or anywhere else, maybe slightly higher in Japan, but still the order of magnitude is the same. How does a machine become viable? It becomes viable based on the number of patients that you're able to put through the MRI. Now, Compressed Sense as a software that enables a throughput or an output of more, making 50% better throughput than what a normal machine has, suddenly makes a machine more viable over here. Again, taking it to tier 2 and tier 3, this makes even more sense. Instead of doing just 10 or 15 patients or 20 or 30 patients, you can raise it to 40, 50 patients, and that suddenly makes it more viable. You get this through insights from customers, so our product decision on where do we focus our sales force on gets dictated by what the customers need. So that's the product part of it. But on the go-to-market side, okay, we have the government segment, the private segment that I spoke about before. The government doesn't have a dearth of patients now because of Ayushman Bharat, but they do not have the business sense to run centers. They do not have radiologists to go and do the studies. This is where the whole PPP model comes in, the public-private partnership. And Philips, we have developed capabilities to work with private practitioners and the government to ensure that we can treat the huge load of patients that is now flowing through the gates of a lot of government as well as private hospitals, saying, hey, we will work on operational efficiencies along with doctors and the government to ensure that most people of Ayushman Bharat get that treatment that they need to get, okay? On the financing side, we've been helping on the private sector. So not only do we provide, say, working capital finance for our distributors and channel partners, we also provide financing for the end customers. If there are young radiologists who suddenly want to buy ultrasound machines, they can't do that from the beginning. We get into revenue sharing type of models. We get into EMI type of models. Now, all this finally helps in furthering that healthcare that I spoke about earlier and treating a bigger load of patients, given and partnering with the government as well, right? You can't make Ayushman Bharat successful without having some of these products and some of these go-to-market models in here. So our strategy is actually based around these to ensure maximum throughput of patients in India.
Thank you. That was an interesting perspective. Sean, if I now ask you this question, and I look at the aspect of strategy, but ask you to focus on the end-to-end element and look at where design really comes in and kicks in, and give us your perspective on that with some examples that you've experienced for yourself.
Yeah, I think going back to what Dr. Nakagawa mentioned, the fact that he's also practiced in Stanford is fantastic because he's been exposed to design thinking now. And at its heart, design thinking is all about building empathy with the users. Now, on the one hand, that's the patients who are looking for better outcomes, of course, but it's, of course, all the people along the continuum who are delivering care. And I think you mentioned, Dr. Raj, the oncology space is an area that we see better coordination now, perhaps, than other clinical areas. And we've been working recently on looking at oncology within Philips and looking at the multidisciplinary team approach and how we can enable a better, more robust exchange of data between the specialists who are within a care team. We sat in on some existing tumor board discussions, for instance, and it was a little bit scary, to be frank. The way that there was a mixture of electronic and paper records coming together. People were pitching in 30 seconds the insights they got from a particular patient, and then making decisions about the treatment pathways based on this quite random collection of information. Now, by understanding the context, understanding the needs of the individuals within that multidisciplinary team, we're able to come with a way of organizing the data, organizing the information, providing a dashboard that would allow them to make more informed decisions about the care pathways. Now, we wouldn't have got there had we just sat in our labs, our design studios, cooking up new software ideas. We only get that by co-creating with clinicians who are practicing in the field every day and seeing how they experience these technologies. And I think that's both the opportunity and the danger from a technology perspective. We've got huge advances in AI, in big data, in machine learning, and things like that. But technology has overpromised and underdelivered to this date in the world of healthcare. And we've got to be conscious of that and make sure that we bring the clinicians and the practitioners along with us. And the way we do that is by co-creating, by using design thinking, and having them design the applications, design the new service lines together with us.
All right, thank you for that. I think we've heard a lot about technology all through the day and the influence that technology can have on healthcare. But Dr. Nakagawa, if I look at your perspective around technology, particularly coming from Japan, how do you see technology play a role, and how can it make a difference in the context of delivering value and value-based care?
I'm not sure if I'm, rightly answering to your questions, but I think understanding, I think, there are so many companies in Japan who has very, very wonderful technologies. Mm-hmm. But as you introduced, we made bedside solution program. This solution program invites industries to the hospitals and affiliated hospitals, and start with the clinical immersion, or in another word, observation of the end-to-air care. Not only university hospital, but care facilities and everything. Because to understand the problem and define the problem is most important things. And unless we define and understand the problem deeply and fundamentally, the technology might sometimes be meaningless. Mm-hmm. And that's the reason we saw so many failure cases. And that's the reason why we started the clinical immersion program in our university hospital. Otherwise, it is not, I don't say meaningless, but it's not sometimes beneficial to the university itself, university hospital itself. But our role is to improve the quality of the care, and also with more efficiently and more, cost effectively. Mm-hmm. So I think, why we started this program was we thought that, academic hostel would be a good hub to, kind of serve as a place for the hub, the co-creation between the industry, designers, and the medical professional. Work together, understand the program together, and leverage the right technology to solve the problems. So, that's what we are doing.
Okay. Thank you for that. It's interesting to see the perspective you get from practitioners on technology as such. So, Dr. Raj, if I turn around to you and then say, how do you view technology, particularly in the context of value-based care?
I think technology is core to this whole value-based care. Although I dare say EMRs are supposed to be core to this, there are challenges, as the previous panel also discussed.
Right.
But having data of a patient in a central holding area, which is accessible to all care providers, will then make sure that you don't repeat a test, you don't overprescribe. All these issues that we currently have with siloed-based healthcare will probably be avoided. Therefore, helping the patient and saving costs, and ensuring better outcomes. So this is again an opportunity to work with industry and co-create, because EMRs, while India hasn't really dived into it, and I'm glad that the government has come up with the National Digital Health Blueprint, which kind of architects this whole thing, or visions out this whole idea for India. We still have to innovate. We have large masses of people who arrive at hospitals. If you go to a busy hospital, you have a doctor who's treating 5 patients across them. And this is like pinging with each patient, and he's multitasking. Mm-hmm. While in the West, physicians are already writing articles about physician burnout, nurses burnout with EMRs. So we need to actually take a new approach, work with industry, and actually come up with a solution where we're able to move from siloed healthcare to value-based care, but using technology at the core, maybe invisible to the care physician, to the treating people, to the doctor or the nurse, but it's at the core.
All right. Thank you for that. Rohit, how would you look at it? I mean, from your perspective and experience, the role of technology.
So I think there are 2 things that I would talk about. One is, a word that's used very often now, or overused, maybe artificial intelligence, machine learning, and all that. I think the kind of volumes that we have in this country need some help, okay? And, artificial intelligence or machine learning, or adaptive intelligence, like we say it in Philips, that is something that helps. The compressed sense example that I gave in the last question was also around, adaptive intelligence. And there are several ways to look at this. India has several small companies now talking about artificial intelligence, which uses data, whether it's X-rays or, all those things. So I think that has a huge role to play in being able to parse through a huge volume of patients, by the small number of specialists that we have. The second one is connectivity. As we spread further and further into tier 2 and tier 3 cities, our connectivity is there. We have some of the best cell phone coverage in the world, okay? We don't have physical fibers maybe, but the cell phone coverage allows us to get in touch with absolutely the remotest parts of the country. And that is where connectivity makes a difference. You don't necessarily have qualified healthcare professionals in all these places, but because of this connectivity, whether it's teleradiology and things like that, you can get good diagnosis to patients absolutely down in the hinterlands of the country as well. So these two things in my mind are absolutely paramount to provide value-based healthcare: artificial intelligence and connectivity.
All right, thank you. So Sean, turning to you, I mean, as a company, we have quite a focus on technology and making it meaningful. But do you have examples that you could explicitly cite where you say that technology has indeed, and this is data-based, in terms of saying that it's made a difference for us in delivering value-based care?
Yeah, I think Jeroen mentioned a number of times the financial sector has been quite advanced in the way they've adopted and utilized technology. But I think if we look at other industries, and one perhaps that comes to mind immediately is the airline industry. And if you look at people like GE Aerospace and Rolls-Royce Aerospace, they're no longer just selling engines to aircraft manufacturers and to operators. They're selling uptime, airtime. So an entirely different business model. Now that business model only works on the basis that these engines are connected and they're firing data real time back into the cloud, which is analyzed so that when that plane is up there, they can predict when it's in need of maintenance and drive efficiency through that. Now, you could liken that as an analogy to the way in which we're looking at imaging equipment, MRIs and CTs. If we understand how it's being used, when it's being used, we can anticipate when there is an issue, when there is a problem, and already come in and fix the issue before it creates any downtime, then that drives efficiency. Now, the other thing is, as we collect data from these devices in the field, we can also start to look at patterns, and through AI, through augmented intelligence, artificial intelligence, understand what is the best use, how can we create new pathways and optimize the use of these devices. So I think by looking at aerospace, perhaps even automotive now is accelerating very quickly through telemetrics as well. We can also advance healthcare in this way.
All right, thank you. I like the analogy that you gave. So I'll ask some of our other speakers if, you can think of an analogy like telecommunication industry. In India, we keep citing this example, we did away with landlines and we really leapfrogged that. Can you think of possible models in adjacencies that could apply, Rohit, to say that if we adopted this, I think there's an opportunity to leapfrog it and value-based care will become the standard way of delivering care in India?
So you're talking about alternate industries where this can happen, sort of,
or
where we can learn
examples from? You can learn from. Yeah.
Well, one of the things I've been thinking about since you popped that question earlier in the day was maybe this industry of home delivery. And I'm not talking about just Amazon, okay? I'm talking about a space which is slightly more specialized than that, and that is of delivering fresh vegetables, let's say. The kind that, say, Big Basket does or something. Mm-hmm. Now, there's a friend of mine who's got a startup in Gurgaon. I think he's spreading to Bangalore as well. It's called Milk Basket. And the concept is not just delivering fresh vegetables. It goes to the complete ethos of getting fresh vegetables in the morning. And he makes deliveries at 7 in the morning. Okay? Sorry? I'll convey that to him as well. Okay? It's 4 o'clock, not 7. Okay. Well, I'm talking about what happens in Gurgaon, and that is before 7 in the morning, before the couple leaves home for their office, they have their fresh vegetables in there. Now, that's a tall order to deliver, okay? But the way they do that is clearly using technology. They can anticipate who's going to order, what they're going to order. And not just, from a perspective of an individual home, but of a community. So the way they expand their business is not by going from one home to the other home to the other home. They go and occupy communities, so one full sort of housing complex, and they anticipate how that's going to work. And that's how they're able to meet that demand at 7 o'clock and even scale it up to an entire city and move to different cities as well. I think that's kind of the way that we have to deliver healthcare as well. look at the problems of an entire community at one shot, anticipate what those issues are, and leverage technology to try to deliver that efficiently.
That makes for an excellent example. Thank you. So, Dr. Raj, how would you view this? How would you look at an alternate industry in your experience that we could learn from?
I would add to what Rohit said. The hospitality industry has been doing this. In fact, besides Amazon, every time we take an Uber, we're giving feedback on the driver, and they're perhaps giving feedback about us. It's two ways. It's customer-centric already. So I think these are examples, and that data is actually looked at by people. So whether it's Swiggy, Uber, or even Airbnb, there's a review about, and the reviews are transparent. So I think we need to learn, even in healthcare, how do we really move from service, fee for service, to patient-centric care.
Yeah, all right. Thank you very much for that. So in light of what I saw in the previous panel, I want to keep some time for the audience. And I'd like to throw it open to the audience now if they had any questions for the panelists. I see a couple of hands up there at the back. Yeah, sure. Yeah.
Hello. I'm Anusha from Bosch Healthcare Services. So my question is, in this digital era, if you still, there is still a field which you can objectify, say in psychology, do you think it is possible to objectify?
So is there any panelist in particular, or anybody can answer the question?
This question is for Dr. Nakagawa.
So the question is, given this digital era, is there a possible to objectify? Can you?
There is still a field which you can objectify. Say psychology. Do you think it is possible we can objectify?
Objectify meaning, can you take an objective view? That's what you mean by objectify.
Yes.
So is there a way you can be objective and not be subjective in this digital age for any health area?
I'm sorry, I apologize if I'm not answering the question appropriately, but I'm for, my expertise is especially traumatic brain injury. And after, we save the patient in emergency center, but the story is not finished there. We follow up the patient for 2 years because we want them to be participated in the societies. And the psychological problem will be very, very, big issues to, achieve those goals. But including my experience in San Francisco General Hospital, I personally feel that, there are a variety of, kind of psychological problems. And some subjective or objective issue could be, monitored by, sensors or something like that. But it's not always easy. And so I think, Tsutsumi-san, the president of the Philips Japan, made co-creation centers in our cities. I'm not sure the exact reason, but we understand why he made the co-creation centers in our cities, because there are a lot of constraints in our district. And after he made a co-creation center, there are a lot of industries, so many companies and so many technology people gathering in those centers. And through, we started to do the discussions. And the bottom line is, through those discussions, we can make some of the metrics or how to evaluate objectively those problems or something like that. So I do not have the direct answers, but co-creation and working together could be only way to solve those issues.
Thank
you. Sean had a view. Please go ahead, Sean.
Maybe just, I'm not quite sure of the context of the question, but if we think about, we do a lot of work in intensive care and acute care situations, so the ICU, for instance, and there the focus has often been on curing the patient, so dealing with the particular illness, the ailment, whatever has happened to that patient, and they're in a critical condition. But what we're trying to do now is, if you take a patient-centric view, is think about not only the cure, but also the care. And when you look at the care side, it's also thinking about how are they going to come out of this ICU? Because quite often it's somewhere in the region of 40% plus of the patients in an ICU will suffer from delirium. And this is because they're often sleep deprived, they're getting woken up at all times of the evening, the night. Lighting is incorrect, so their circadian rhythm's completely thrown out. So if we start to look at the needs of the patient and the psychology of how you're going to feel better beyond just curing the illness, then we will come with new solutions and new ways of delivering care. And that's some project work that we've been doing recently. Yeah.
All right.
Yes. Thank you both.
Thank you for that. Please go ahead.
Yeah, I'm Ananta Padmanabhan. I'm coming from MGM Healthcare in Chennai. It's been recently inaugurated, and we have implemented the charting solutions, IoT-enabled solutions. Maybe even we are working on some AI applications in monitoring and ventilation. But my only concern is, in the last 30 years, I've been working in the hospitals in India. Out of maybe about 10,000 hospitals in this country, they may be in the government sector or in the private sector, small hospitals, big hospitals. Out of the 10,000 hospitals, my understanding is only about 8 to 10% of the hospitals have a formal HIS system, hospital information system. Not to talk about EMR. Hardly about 2% of the hospitals in this country have only EMR. So if this is going to be the computerization, if it is going to be the IT penetration in the hospital, how can we talk about artificial intelligence, IoT-enabled systems, connected health in this country?
All right, I'll address that to you, Dr. Raj. I think you're best equipped to answer that.
Thank you. I think you've actually highlighted the actual current status of the country, the digitization in our country. And that's the biggest challenge and an opportunity. And if you just, I'm not sure if you've seen the recent framework that the government is planning. There was no framework till now, so every entity created a software and deployed it, some kind of an ERP system in most hospitals, at least the hospitals you stated. Most of them don't comply with standards. If you try and compare data from one hospital to another, you'll never be able to merge them. What's interesting in this whole framework that the government is proposing is a federated architecture where each hospital can have their own data, their own softwares, but create a system wherein we exchange data. It's going to be difficult, but yes, at least the framework is now listed out. It's put up by the Ministry of Health, and it's for us, doctors, as well as the industry, to actually take this opportunity and try and work towards working with standards which are prescribed. And I'm sure at some point it will become mandatory that every healthcare center, if they have to receive benefits like the Ayushman Bharat, has to be digitized. It's already becoming a mandate for the hospitals which are NABH certified, for example. So it'll soon become a mandate to digitize. Patients will demand it, especially if they're able to access their data. But yes, it has been slow, but one is seeing acceleration and a movement from the government by defining such standards and defining a vision, which definitely gives a great opportunity for all of us, engineers, design thinkers, designers and everyone, and the healthcare fraternity to work together.
Thank you. There are a couple of hands up.
Yep. Here, out here, yep. So I didn't plunge my hand open first because the AC is turned too, it's too strong. So I was just trying to warm up myself first. Anyways, I am Dr. Amol. I'm a medical doctor by qualification. And currently I'm a VP of a healthcare consulting firm called as BioQuest. So I would like to take cue from the previous person who asked the question. I believe the spirit is in the right direction, that the government started NRHM, moved on to have NUHM, and now the National Digital Health Mission. So this question is to Dr. Tony, and any of the panelists can answer this. But most importantly, I would like to share an important analogy. You did mention in the beginning, Dr. Tony, that healthcare has become so siloed. There is a lot of specialization, ultra-specialization, and somehow I believe that patients nowadays, they fear. It is like You pick the specialist, pick the disease, right? You go to a cardiologist with a chest pain, he says you have unstable angina. You go to a psychiatrist, he says that you are having a panic attack. Anyways, so I have just 3 sub-questions to any of the panelists. See, first and foremost, when we speak about value-based models, are we restricting ourselves to only diseases which are chronic in nature? Why not diseases which are acute by nature, something like infections or accidents, what traumatic brain injury which Dr. Nakagawa mentioned? The number 2 is, whenever we are speaking about value-based models, we feel that the only solution that we see is integration of various specialities. Is that the only answer? And the third one is, if you might have seen in the recent tabloids and so, whenever we speak about the value-based, the focus is on the care. And there have been 2 medications in the value-based models which actually cost more than $1 million. So how do we actually tackle these things? Over to you, please.
I'll probably start with your first question. Is it restricted to chronic diseases? No, I don't think it should be restricted to just chronic disease. As you pointed out, trauma care is an ideal example, and it's critical because typically what happens in any so-called casualty or an emergency medicine department, a patient arrives, the emergency physician looks at it, then calls, if there's a fracture, calls the orthopedician, next calls the neurosurgeon if you see a head injury, next calls an endocrinologist if you suspect any other problem. But as you can see, it's still siloed. Just imagine if you have a care team of 3 people together, at least the core team, looking at and saying, okay, we'll take this decision. Let's save time and take a decision that saves the patient's life or saves time. I think that's critical. So acute trauma is one, infectious diseases, we can pick up examples, but I think there should be an intent for hospitals, health systems to accept this model and move forward.
All right. So there's a hand up there. Go ahead, please. Yeah.
My question is again to Dr. Raj. You gave a beautiful example of how St. John is using value-based system for people from economically weaker strata of the society. We saw with Ayushman Bharat, Shiva also talked about the government has come up with some innovations, but what we see in the private sector, let's say OPD reimbursement for insurance or healthcare at home, even among the private insurance, these kind of services which are part of a value-based care are not at a full adoption. Do you think that with a country of 130 crore, government is in a position to go to that level yet?
I'm not really sure how the business model works when you scale up, but yes, if hospitals can think about how do we serve patients who don't have money and who don't have insurance, I'm sure, again, innovative thinking about process workflows, how do you deal with a patient you need to work out a model. I'm not really sure about scaling up. If you're asking whether the government can afford it, no. Our country, I don't think our health budgets permit, we need to shift our budgets from spending on other things to health. That'll change, but that'll change things. But in the current system, I don't think, if we scale, we may have challenges. But it's again, private hospitals, not-for-profit hospitals should think about models, work with insurance companies and see if we can work out a solution to, come with care pathways that work for affordable healthcare using technology. I'm sure we can come up with solutions.
All right, the Master of Ceremonies has signaled, so I shall close the panel. Thank you very much, panelists. Yeah. Thank you for the session.
If you can just hang on there for just 5 more seconds. Yeah. If I can request Rohit to hand over a token of appreciation to Professor Nakagawa, and Sean to hand over the token of appreciation to Dr. Tony.
Yes.
Thank you so much.
Thank you.